Okay, well, good morning, and thank you very much for joining us on the webinar this morning. I have, in fact, Dr. Kerry Zang. As you probably have already read his bio, Dr. Zang joins us from the US and is able to take us through the slides and commence the webinar. We are able to take questions, and I guess, is it okay with you, Dr. Kerry, if we take the questions and answer them at the end of your presentation?
That's absolutely fine.
Perfect. Okay, well, thank you very much for joining us, and over to you, Dr. Zang.
Thank you. So today we're going to talk about onychomycosis with the non-thermal lasers. This has been a lot of discussions regarding the thermal versus the non-thermals, and in reality, it was the thermal lasers that entered the market many years ago, the first one being Pinpoint, and then there's been 3 or 4 others, and those are actually class 4 lasers. The non-thermal lasers are class 3 lasers. And we're going to go through some slides, just some background, and I can tell you once we get into, we're going to be very heavy into the clinical, and we'll show you some things with some of the treatments that have been ongoing that you might not have been aware of. And at the end of the lecture, if you'd like, I'm happy to take questions about how we talk to our patients about this and our different protocols, because with onychomycosis, I mean, that's been the enemy of the podiatry community because most of our patients have it. And up until now, we've really never had a good treatment for it. So let's just go through the some of the background, and then we'll get into the actual clinical part, which I think most of you are probably interested in. So low-level laser therapy is cold laser. It's in wavelengths that are 650 or lower. The hot lasers are wavelengths of 800 and higher. The Pinpoint laser, actually, the wavelength was around 1200. So the main issue that we have, everybody knows the fungal infection of the nail. The infection is in the nail bed, the germinal layer, and the nail plate under the surface. And this is where the problem comes in. If you can see my pointer, it's the germinal layer that harbors the actual mycosis, and the hot lasers cannot access that area at all. So the infectious agent permeates the keratin layers, and it results in the discoloration, disfigurement, hypertrophy of the nail, the subungual debris, pressure, and pain. It's estimated over 10% of the population has clinical nail fungus. United States has 31 million, Canada 3.4, Mexico is 11 million, Europe is 86 million. Areas that have a higher moisture rate and colder temperatures, which require you to wear closed shoes, has a little bit higher rate. In the US, the Medicare spends over $43 million a year to treat it, and 250 million were spent on just nail debridement with no attempt at trying to eliminate the mycosis, period. This has become somewhat of a financial burden in some of the Western cultures. So the medication accounted for 85 million in expenditures from 2013, and it's 21% annual increase. So the permeability of the nail plate, it behaves like a concentrated hydrophilic membrane with multiple layers, and they have different barrier properties, but that makes it almost impossible for our topical agents to get to the actual root of the problem. They can't access the actual fungus because of the medication is prevented from getting there. You know, in the United States, Jubilee, I don't know if it's in Australia or not, but Jubilee got FDA approval with only a 17% clinical clear rate, not even a cure rate. And in the United States, it's about 500 US dollars a month to treat this condition, and you have to use it for a year, and it's not without side effects. When you use Jublia for an extended period of time, you have a lot of irritation along the nail folds, and it just doesn't work very well. And the other topical medications are down around the 10 to 12% success rate, and most of them used to be prescriptions here. So the problem is that the fungi produce a chemical which inhibit the production of phagocytes. The phagocyte numbers are reduced, and the environment for fungal growth then ensues. And that's exactly what the inside of a shoe is. It's hot, warm, and moist. So you have a psychosocial effect too, So, if he likes the fungus, why is he here? No, I said it's growing on me. And this is really it's a very big issue, the psychosocial aspect of it. And I was asking your distributors there, who they thought would be the main people that we treat in the United States, and most people say it's women, and that's not really the case. In the United States, most of the people that we see are men 30 to 50 years old, recently divorced. So, that's I don't know if that's a problem in Australia, but here that's who we see most of, and then it's women. So when you talk about the mainstay therapies, griseofulvin, which has been used for years, you have to treat it for a year and a half, follow-ups a year and a half, and the success rate was only 13% or 14%. Terbinafine is 12 weeks, follow-up of 48 weeks, it's 59%, 58%. There's part of my screen is blocked off, so I'm not sure of the numbers there, but it's pretty close. Itraconazole, 12 weeks, 72-week follow-up, only 38%, and fluconazole is 6 months and follow-up and a little over a year at 49%. And they're not without the toxicity and side effects on the liver enzymes. You should go ahead, get liver enzymes before you place the patients on this. And the biggest problem that we have here is that our population that seeks treatment and has concerns with nail fungus generally are 60 and older. And these are the patients that are also on antihypertensive medication, cholesterol modifying medications, medications to control blood sugar. And all of these also can have an effect on the liver. So if they're taking these medications and you end up with the abnormal liver function tests because you added some of the oral systemic medication, you have to stop all the medication and then start adding them back one by one to find out what the cause for that was. So what's the solution? We've been looking for a solution for years, and its solution, in my opinion, is low-level laser therapy. Cold laser therapy, the light penetrates the nail bed. We use a dual diode device that combines the antifungal effects of the 405 nanometer wavelength with the regenerative outcomes of the 635 wavelength. This gives the maximization of photon concentration and initiates photobiomodulation. And the device that's been developed by Erconia has a proprietary 6-inch laser beam where the concentration is equal, not just in the center part, but it's equal throughout. And it can also penetrate down into the germinal layer and the nail matrix layer. When we first started this years ago, I was skeptical. As a matter of fact, when it's funny, when I first met the people from Erconia, and this is probably in the late 90s when they brought their cold laser to me. I thought they were trying to sell me a voodoo device. And since that time, I've actually had to eat my words, and we use lasers of all in all of our medicine, and hopefully, and if they want me to come on back, I'll be able to lecture on the cold laser for musculoskeletal. But for clinical nail mycosis, with what you're seeing here, I went ahead, and with a sterile nail nipper, I took a patient that had a very thickened, clearly mycotic nail, subungual debris, all the clinical signs, and I trimmed the nail in one piece, captured it in a sterile environment, took that particular nail specimen, cut it in half with a sterile device. I put one half of it immediately into the media. The other half I put on sterile device into the lunular device, irradiated it for 12 minutes, and then placed it in the same media. They were placed side by side, and we had mixed infection on the left, the untreated one, and zero on the right. And we've been able to repeat this consistently. So, and we'll go on with regards to how this mechanism actually occurs, but it did destroy the mycosis in the nail almost immediately. So with this dual diode approach, it sets up an internal biochemical mechanism. This is totally different than the thermal lasers. The thermal lasers work by just cooking the material, and we'll go into that in detail a little bit later. But the 635 wavelength is the wavelength that increases immune constituents. It activates the actual regenerative cycle. It mobilizes the patient's own growth factors to come to the area. It's mitochondrial stimulation. It increases nitric oxide, which increases the macrophage and neutrophil cells to come to the area. And it also increases the vascularity. And when you take that and then you combine it with the 405, the lower wavelength, this increases the production of reactive oxygen species, which results in antibacterial, antifungal, antiviral benefits. The 405 wavelengths produces superoxide dismutase, which is an enzyme which results in the lipid perioxidation in the cell membrane of the fungus. It degrades the phospholipids within the fungal cell, and it results in cell death. But it just targets the abnormal cells. So what it does, it enhances the eradication of the infectious agent. This also, by the way, you can, if you have patients that have little diabetic ulcerations on the toes or the digits, you can put their feet into this device and it'll kill the bacteria. It'll kill it without having to do, if they're too fragile for debridement. And it'll also increase the microcirculation. So it's not only just for clinical mycosis. If you have the machine, you can certainly use it in your diabetic patients. It would be most beneficial. But in any event, the 635 wavelength breaks down the infection, and it also accelerates the growth of a clearer, healthier nail by mitochondrial stimulation, increasing nitric oxide, increasing vascularity, while the 405 blue light provides antimicrobial, antibacterial, antifungal effects. So basically, it starts the phagocytic process, which has been lost with in the treatment of nail fungus, because none of the medications topically that we use can get down there. So with vascular, there have been numerous studies which does show an increase that it shows that patients that have onychomycosis have an increase in diminished vascular supply. And poor blood flow engenders immunosuppressant, which also it reduces your benefits against fungal infection. So in another study, the low-level laser, the 635 wavelength, increases perfusion to the skin. And this actually increases the circulation. And this is a study that I did. We have Doppler ultrasound in our office. And I just took a patient with clinical nail mycosis, and I gave them the 12-minute treatment. This is the right hallux. And then I repeated the ultrasound Doppler, same tech, same settings within 3 minutes after the patient was in the device. And you look at the change in the vascularity. And the vascularity increases dramatically. Now, this is the same thing that happens in the Achilles tendon, pre and post treatment, in the plantar fascia, in the musculoskeletal, and myositis. So, and we have different protocols where we treat these, but basically, when you're using vascularity, increasing the vascularity, with the laser, it's generally 2 steps forward, 1 step back. So we have other studies, and that's a different lecture, but we have other studies where we show that when we give it one treatment with the laser, you get this response, it retreats back, and then when you go to give the second treatment a week later, instead of it just being in this small area, you see it up and through here and a little bit down and through here. You treat it again, and then it goes from here up to here. And after 4 treatments, you get rid of the vascular spasm. And that's also why this device, if you're dealing with digital ulcerations, why this device works so well in clearing up not only the infection, but it increases the microvascular supply, and it is sustained. And I know that has nothing to do with with onychomycosis, but I mean, you have a device and you can use it for a lot of other things. So your mechanism of action is a combination of the 405 nanometer wavelength and the 635 wavelengths, and it produces acidic nitric, and you develop peroxynitrite. The 405 lower wavelength, which is the blue light, is the active producer of reactive oxygen species. The 635 produces nitric oxide. Together they produce peroxynitrite, which causes the destruction of the fungal pathogen. So as you lower the wavelength, you increase the power. When you have a higher wavelength, you have deeper penetration. But the combination, and the 405 does trigger pronounced photochemical reaction in the superficial cells, i.e. the fungus, and it results in target cell death. So the lower the wavelength, less skin penetration, but more activity you have within the superficial layers. The higher wavelengths, the deeper the penetration down into the subcutaneous tissues, which you saw with the 635 wavelength. So there's only 2 or 3 more of these more boring slides. So, but with photooxidation, your generation of molecular oxygen is excited in a single state, and its primary cause of cell damage is in connection with photodynamic therapy. We're actually creating a therapeutic change and physiologic change, whereas the heat lasers solely work by burning the tissue. And there's no way to control what it burns. It burns dependent upon the length of time that it's in contact with the tissue. And if you spend 10 minutes paintbrushing, if you will, a a mycotic nail, and if you miss one spot, it's going to reinfect the nail again. So when you have that, when you have this photooxidation occurs, it repeats itself with the lasers. The laser constantly reactivates the cells. So it transfers the energy from photosensitizer to an excited triplet state to molecular oxygen. It's the oxygen, the transfer, that relaxes to its ground state from where it can be re-excited under the influence of coherent light. The cycle is repeated. And so when you're treating these patients for 12 minutes, you get 12 minutes of constant therapeutics to the entire nail surface and germinal layer. And it reacts with the proteins, nucleic acids, unsaturated lipids. The diffusion of a singlet oxygen is less than a million microns. It's so small, it's less than 1% of the size of a red blood cell. But it is a lipophilic, it accumulates in the plasma and cell membranes, and this photooxidation can result in direct rupture of that membrane, which is in the fungus. So let's just talk about the difference between the thermal and the non-thermal layers. I don't know how many of you have had the experience to actually see either the lunula laser in action or any of the thermal layers in action. But I can tell you that the thermal layers, when you're actually in the room when it's being done, you can smell the plume. Well, when you're smelling the plume, it's too late. You're actually breathing in pathogens, microbes, virus, fungus, and so is your patient, and so is everybody else in the room. Back in the late 80s, when they came out with the carbon dioxide lasers, which were pretty much in the same category as the pinpoint, for example, and I did some research with those lasers as well. That was a true surgical laser, but we had to have special charcoal filters. We had to wear charcoal masks, and we had to mask the patient. And that was in the middle to late 80s when we did those studies. And yet that does not happen with the practices that are using the thermal layers. They're not told to use that, so they don't use it. But if any of you have been there, you can actually smell the plume. You smell the plume, you're playing Russian roulette. So you have none of that with the non-thermal laser. You have it with the thermal laser. There is no antimicrobial or antifungal physiologic benefit with the hot lasers as there is with the cold lasers. The patients constantly have to be asked to tell them when they have pain with the thermal lasers, as you have to keep on going over the area. However, in our population base, I mean, how many patients of ours have neuropathy, have diabetes, have insensate feet, and they can't feel it. They can't tell you when the pain is there. And also, if you're feeling the pain when you're going through the nail plate, you've gone too far, because you start to get the pain when you start burning the periosteum on the dorsal aspect of the phalanx. Then you're getting thermal burns, and burns take a long time to heal, and in this area predisposes the patient to bone infection. That is a definite problem with the thermal layers. It is not an issue with the class 3 cold lasers. Same thing with risk of burning. It is safe to use in the cold lasers, are safe to use in the diabetic insensate foot. They are not safe with the thermal lasers. Risk of complications are present with the thermal lasers. There have been no reported complications with the cold lasers, either in musculoskeletal work and in the dermatology world and in the nail fungus world. And this treats the entire nail and nail bed and germinal layer. The cold laser, the thermal laser, cannot treat the germinal layer because it can't go through the skin to reach it. And one of the things is with the thermal laser, you have to pinpoint each toenail. It's very labor intensive for the doctor. You can't have a staff person do it. If somebody has all 10 toenails involved, it can take you an hour. With the Lunula dual diode device, it's very doctor friendly. All you have to do is teach your assistant how to push a button. And in our office, we used to put on I Love Lucy on video for people to watch it for the 12 minutes that they were treated. But when that treatment is being done, you can be in the other room treating other patients. So this, probably 2014, when the pinpoint went to Europe, this came out, and this is a result of the 1064 hot laser. And this went on to lose portions of the toes. I mean, the physician that did this did not check with the patient of what their, if they had medical comorbidities. This was a diabetic patient with vascular insufficiency, and they just, this is certainly one of the worst results that you can see. Unfortunately, it's been fairly common in the United States. There's been the negligent cases that have been involving the hot lasers, all involve burning of tissue, osteomyelitis, and even loss of some digits. There's been no issues whatsoever with the non-thermal laser. As a matter of fact, the worst thing that can happen with the cold laser is nothing. You cannot hurt the patient with it. If the treatment doesn't work, they still have the condition present, but you've done no harm. So let's talk about Robert Sullivan's study. We spoke with Dr. Sullivan in Europe. He's a podiatrist in Ireland, and he did a companion study to what we had done. And we spoke on the phone a little bit. I explained to him what I was doing a little bit. He did a very similar protocols, and we never compared our results until afterwards, and they were really fairly close. In his study, he went ahead and he treated the affected nails for, gave him 4 treatments and did his follow-up at 48 weeks. And his success rate for clearing was an 84+%. And those were nails that generally had 20% involvement or more. It was 51% effective on nails that were totally included. And when he's talking about totally included, he was talking about nails that the mycosis went down to and went underneath and into the area of the germinal layer. And there was loss of structure. So he included some very significant patients with significant nail disease. So at 48 weeks, he was really had pretty good results, ending up somewhere around 85%. And you can see these are pictures of his nails before and after, top and bottom. And you can see in certain areas, you can see like a little circle here. I'm going to go over that in detail later. You see these lines here. So, and I think we have some clearer pictures for you. When you look at this is at 48 weeks, but the baseline study, you can see the involvement. Look at the second digit toenail. Look at 3 months. You can see it starting to clear. You can see it clearing here. We did our study. The difference in our study was down to about, we gave the 4 treatments and we checked them at 26 weeks for clear nail growth. And you'll see some different markings with that. But look how the change is, and look how thick it looks here. And here you can now start to see the new growth pattern. And this is at a year. Again, and I wanted to go back to show you, look at the second digit toenail again. I mean, you have pretty good clearing with very little to no risk. And you can see how hard this is, but look at the difference. It almost looks like it's trying to melt or become more porous, but it really doesn't change the nail structure. You have to wait until the nail grows out. And his pictures were a little bit different than ours, but you'll see again, look at the second digit toenail. At week 4, look at the difference in the second digit toenail, and look at 48 week, it's clear. Now we go into our study, and our study that we got the FDA clearance on was 1 treatment once a week for 4 weeks. And then we would check the patient at in between, and then again at 26 weeks. And our objective was to assess the efficiency of non-thermal laser for onychomycosis. We used the dual diode device of 635 and 405 that we went over earlier. We measured the toenails, included the analysis based on identical onychomycosis, thickened discolored nail plate, confirmed etiology via culture, and the FDA was interested in wanting to know that we had greater than 3 millimeters of clear nail growth during the 6-month period. So most of the treated toenails, 67%, achieved that. We had an 89% treated toenails indicating success across a 6-month period. No adverse effects were reported. Non-thermal laser therapy is safe and effective for increasing the extent of clear nail growth in onychomycosis, and follow-up treatment for 4 weeks. So when we're looking at this study, when you look over here, you can look at the circle here, look at this, like you can see another distinct line over here and another one down here. When you look at that, you see how quick the near place. This is when the first laser treatment was administered. Second laser treatment was down around here. You can see it. You'll see it better in other slides, but you can see the change in the thickness of the nail as it's growing. The third laser treatment was down here. You can see like the little laser treatment line. And then you can see how quickly the nail growth becomes faster with multiple laser treatments. And when you look over here at 26 weeks, the nail hasn't grown out completely, but clearly at the 48-week period, we did have clearness. Same thing with the Sullivan study. The FDA wanted to have us clear near earlier, but you can see where each laser treatment was given. And with each laser treatment, the growth of the nail was faster. Again, first laser treatment, second laser treatment, and it's either here or here. It's hard for me to see on this one. But again, at 26 weeks, you can see the growth, and this just grew out a clear nail. Again, you can see the different, you can actually see the lines coming down and stopping with each of the laser treatments. Again, you can see our treatment. Here's our first laser. It just stops this clearing up quicker. Here's the next laser treatment, and the fourth one was down here. And as it grows out, you can actually, this one has grown out, but you can see the line here and the line over here. Are these being visible, Ann? Okay, thank you. So our clear nail bed at 6 months was 79%. And the dual diode, the average clearing in 6 months following 4 treatments was 87%. If a positive response to treatment and with the absence of any adverse effects. So these are the studies, and this was a 7-year study with the FDA. So you can actually see the treatments, and you can see the dates from where they're right around 6 months. First treatment, and you can see the first treatment line was right over here. Second treatment line, not so much nail growth, but you can see the laser. It's like the rings on a tree. And then the third laser treatment, you can see how the nail was right down to here. Each time it cleared up more, but there was significantly greater nail growth. So you can see it, the density changes here. First treatment, second treatment, third. You can actually see the line as it grows out. That's with 4 treatments. Now, at the end of the lecture, we modify our protocols dependent upon the patient, dependent on the patient's comorbidities, and I'll be happy to go over that with you as well. And we should have plenty of time to do that.
Thank you.
Again, yes, Ann?
No, I was just going, that would be great. If you could
Okay.
just go over the
So-
protocols, that would be great.
So you can actually see the treatment lines with each treatment. So it definitely has a very definite physiologic effect. Again, the treatment lines. This was really quite amazing for us because we didn't expect that to look like that to happen. And you basically, to know whether you have a success or failure, it's what's happening down here as this starts to grow out normally. And some patients, younger patients, grow faster. Their vascular supply is better. They have less inflammation of the localized vascular supply, less cholesterol issues. So, but you have to check with all your patients and try and tailor the process for them. So these are other pictures. Again, look at the second digit, the clearing that occurs. And it occurs, we had to use special cameras for the FDA, so we couldn't get the other toenails involved. But even here, you can see a little bit, you see the fungus over here, and it does it without harm. When you look at this here, you can see when you have this red light and the violet light, and when you look at it comes across, you'll see the violet light will come. Oh, why did I stop that? Okay. The violet light will come even outside of it. So it does get all of the toenails. And the, let's see. So for the FDA, it was treatment once a week for 4 weeks, and then we just watched it. So basically, if we are in our protocols, when it's an obvious clinical mycosis, it's up to you if you want to do a culture or not. When patients come in, it might not be a bad idea to do cultures, because when patients see a positive culture, it sort of reinforces to them why they're coming to you. If people are coming to you for a cosmetic reasons, you really want to make sure that it's a clinical fungus. We ask our patients, when patients come in for heel pain or come in with bunion pain or neuroma pain, and we see mycosis, and they're not coming in for the nail treatment, just casually, when I'm taking care of their other condition, I ask them how long they've had the fungus or what appears to be a fungus. And a lot of them, surprisingly, I'll say, well, I've had it for 5 years. My doctor told me that he doesn't want to give me the pills for it because it's dangerous and there's nothing you could do for it. So, I agree with him that the systemic antifungals are not my first choice of treatment. I don't use those medications because there is a 7% chance of adverse reaction, and there's only a 60% success rate with them. And by the way, years ago when this came out, and I was talking to my dermatology friends, and they say they don't like to give systemic medications. I happen to ask them why. What else do you do? They say nothing. I say, don't you treat their shoes? And it was like, that's like what's the matter with me? You're right, because they're all getting reinfected. For every patient that we put on this protocol, we have them use a Lamisil spray or any antifungal spray. We have them take all of their shoes outside because that spray stinks, but we have them spray all of their closed-toed shoes. And then we have them keep the spray in their closet. And whenever they take off a pair of closed-toed shoes, just a 2-second spray in the toe part will sanitize those shoes. So that'll help reduce the risk for reinfection, whether the patient puts the shoes on the next day or 2 weeks or 2 months later. So we do treat a lot of shoes. Also, when patients come in and want the treatment, I do ask them, this is at the point where they already want the treatment. I ask them if their spouse or significant other has nail fungus. And if they do, if they tell me that they do have it, I will not treat them unless they bring their spouse in and they undergo the same treatment at the same time. And people think, well, that's a big deal from a economic point of view, but usually it's the woman comes in for the fungus, but she got it from her husband or partner or whoever, and I won't treat them. And I can tell you, in all the years, I've had them bring in their significant others kicking and screaming, but I've never had one not do it. And, they're going to sleep in the same bed. They're going to shower in the same shower. They're going to transfer it. Other things that I talk to their patients about, I ask them quite frankly, especially if they're not coming in for it, I do ask them if they've had any issues elsewhere. And they just say, what do I mean? I said, do you have any itchiness in your groin area? And they look at me and they say, why? Well, so this is a fungus. I said, how do you put your underwear on? You're going to transfer it from different parts of your body. And that gets, you'd be surprised how many people that it rings true to them. And you're not insulting them at all. You're just being a good physician. You're taking care of your patient. And nobody likes to have the fungus on them. Okay. Economically, I can tell you in our office, we do a series of treatments. We generally charge $785. You can charge whatever. I don't know what it is. I don't know what the conversion rate is, but I charge $745 for 4 treatments. I reevaluate the patient in 16 weeks. That gives us enough time to see if we're starting to have new proximal nail growth, which is healthy. Usually it's at least 3 to 4 millimeters, but it's a start. As a goodwill gesture to my patients while they're there, I generally just give them another treatment. And generally when nails come in, if it's 50% or less, the 4 treatments are probably going to do it. If they're 85 to 90%, then maybe they need another series you could do it at 16 weeks, or I do it at 6 months. And we charge half rate for the next series of 4. The other thing that we do with these patients, we ask them to put it in their phone, the anniversary of 1 year in their phone. And if they wish, even though the fungus is totally clear, if they wish, they can come in and we charge them $100 we treat all 10 toenails with the lunula. And you'd be surprised how many patients come in, and it's goodwill. You're taking care of them, you're helping to prevent it. I do have them continue the spray in the shoes, because if you have the genetic makeup to catch it the first time, if it comes back in 3 to 5 years, whatever, and the patients say, well, you used the laser, and I just tell them, well, if you have strep throat and you go to the ER and they give you penicillin and it gets rid of it, you feel great. And then next year you get strep throat again. It's not because the penicillin didn't kill it the first time. It's because you got reinfected. Yeah. This is an infection. So you have to be diligent to take care of this. One of the things that we have done, we have just submitted to the FDA, so the paper won't be available probably for another 4 months or so. But we use the same protocol once a week for 4 weeks. We cultured every patient. At the end of 4 weeks, we cultured them again, and then we had the patients come in once a month for an additional 11 months. So it's a year. They got low-level laser. Before the laser treatment, each month, we took another culture. We took it from the same spot that we did initially. And after about 2 or 3 months, all the cultures came back negative. So the FDA is probably going to give Erconia the first okay for actually a mycologic cure. None of the hot lasers have a mycologic cure. They just have temporary clearing of the nail. But we wanted to do this. And also when we did this, and we had, I think we had 53, 54 patients that was in that additional study. And the success rate went up also from the 89% of clear nail up to about 96%. So it's important that you evaluate each one of your patients. You know, a patient that's 60 years old and plays golf 3 times a week and jogs and has no health issues is going to respond in all probability much faster to 4 treatments than the 72-year-old that has uncontrolled diabetes, has elevation-induced claudication, which indicates that they've got vascular compromise. It's going to take that patient much longer, and you have to be very transparent with your patients. I just
Absolutely.
let them know.
Yeah.
You have medical comorbidities. This machine, the cold laser, does a very good job, but it's not magic.
Thank you.
Okay.
Would it be a good opportunity now for me to just put to you a couple of questions that have been asked?
Sure.
So firstly, all those cases had only 4 treatments of cold laser.
Right.
What was the time frame of each session and how long was the follow-ups?
Well, these patients, in the Sullivan study, his follow-up was 48 months. In the paper that we did for the FDA, the official follow-up was 26 weeks. That's what the FDA wanted, but we followed those patients for a year. So our results held true. Each treatment session for those patients was 12 minutes, and we treated all 10 toenails.
Perfect.
Right. We treated not just that one. So we treated all of them in case there was some subclinical mycosis on the other foot, and then it transferred back. So it was 12-minute session once a week for 4 weeks.
Sure. Thank you.
That's what you saw in every one of those slides today.
Sure. Thank you. And a second question. My big toenail is very thick and greenish black. In 2016, I tried thermal laser. I think it was the one that gets very hot. It did not cure my toenail fungus. Will the cold laser work for me?
When you have thickened nails like that, I have little faith in the thermal lasers because the thermal lasers have no physiologic benefit. They burn and they kill whatever they hit. And if that person spent 10, 15 minutes using the hot laser and asking you if it got hot or not, if it never got hot, he probably never penetrated down to the basal layer. So that layer was probably never treated. If it did get hot, fortunately, your vascular supply was good, so you didn't get a thermal burn. But when you paint that, you have to get 100% of the nail, and that's virtually impossible when you're using spots, 1, 2, 3 like this. And if you miss a couple of spots, then the nail, if the fungus is there, it's just going to reinvade the tissue, and the tissue that it will be reinvading is less viable than it was beforehand because it was already diseased. So will it work for you? If it involved your entire toenail, I think you probably should have the treatment once a week for 4 weeks. And if there's not a dramatic change in 16 weeks, another series of 4. I mean, there are some toenails, as physicians, we'll look at toenails and we're going to say, oh my God, we're never going to get rid of this, and sometimes you can't. But
Yes.
with the real aggressive and true fungal nails, if you give it the treatments, the patients that got it once a month after the first treatment, patients were in that category, they got better. But,
sure.
And sometimes if it's just one toenail, and if it's secondary to a traumatic incident, you may be dealing with something more than just a fungus.
Yes. Just another question that's coming from Charlie. Hello, Charlie. Should we use topical along with the laser together at the same time during the period?
I think that's a good idea. And I use it in clinical practice. And I just have them use over the counter. You can use cycloporox. You can any of the ones that we've had.
Sure.
That used to be prescription. You can use that. However, in the study, on every patient that you saw in the study, there were no topical agents used, none.
Okay, thank you. And another question, do you recommend physically debriding the infected nail, sublingual debris before LLT treatment? So I guess they're asking, should it always be done before any laser treatment period, the full debridement?
Well, I personally, in our practice and with our other doctors there, we do not debride the nail. Some people debride it because that's what we're used to doing, especially if we have practices where we do a lot of diabetic care, we do a lot of conservative care, but it's not necessary. And sometimes when you see the thicker toenail, it's a lot easier for you to tell the new clear nail growth that is occurring. And the other issue that you have now, they don't really allow us, OSHA does not allow us to use the nail debridement now because we're throwing up active microbes that we're breathing as physicians, even if you have a mask. Yes. And patients are breathing it. So no, okay. I don't use it, but I think it's a personal choice.
Okay. And another question, if we may. Some patients want to know why we have a break after the first 4 weeks. They want to keep going on for longer. Is this safe?
It is absolutely safe. The reason why we wait for 4 weeks is that we know histologically that when I give a laser treatment for 4 weeks, the vascular supply remains sustained to the area. If we go for 4 weeks and then we have a break, then we'll be able to actually see the nail may grow a 0.5 millimeter a week. So we want to give it 10, 12, 16 weeks after the initial treatment, so we can actually visualize the new nail growth. You saw all the rings that we were creating, and you can actually see that. But it is absolutely safe. You could use this laser treatment every single day for a year, and the worst thing that can happen is nothing.
Good to know. Just for the benefit of the attendees on the webinar, are there any more questions that you'd like to submit before we do the summary? If you'd like to type them onto your panel now, and we can put them to Dr. Zang.
If anybody has any questions, they can certainly email them to you. You can email them to me, and I'll do my best to get the answers back to them.
Thank you. I think, we've covered every question that's come in so far. So did you have any more to add as a summary, Dr. Zang?
I think that in today's world, this gives us a very safe option to treat our patients. And when we're treating our patients with nail mycosis, we're treating more than just the toe. I mean, These patients, the patients, they don't like the idea that something is growing on them.
No.
And it is really a psychosocial condition as well as an actual medical condition. And patients are looking for some sort of help for this. That's why it's so common, and that's why people are asking about it. But if we don't treat them, somebody else will.
Yes, yeah, absolutely. Okay, well, thank you very much for your time, Dr. Kerry Zang. If any of the participants would like to ask questions at a later time, they can actually do it through ReaCare. and we can actually send them through to Dr. Kerry and for answer and clarification. So if that's the last of the questions, there's nothing else coming through. Thank you very much, and I'm sure we'll be in touch soon.
Thank you.
Thank you, Dr. Zang, and thank you everyone for joining this session with us today.
Thank you. Bye-bye.
Thank you.
Bye-bye now.